Hunter Brendan Leahy is, no, yes, is not yet officially a member. She starts after July 1st. And so with Roberta coming off at the end of this term, but she's already gone, we're pretty short on quorum. But Arthur's back and he's been emailing today, so he should be in, right? Is he there? There he is. I see Arthur. Is Linda coming? She was in Canada. Jeanette is going to be attending by car. Here she is. What do you say? Bree, are we ready to go? Uh-oh, Arthur, Arthur's not able to speak. Okay. Let me see. Are we ready to?
That was cool. Ready to launch?
Yeah, let's go.
All right, I read. Any interested person may submit testimony in writing to the board on any agenda item by regular mail, email, or fax. An individual or rep wishing to testify in person should register prior to the start of the meeting. Testimony must be related to an item that's on the agenda, and such person shall be required to identify the agenda item to be addressed by the testimony. Submit testimony by one of the following methods. Email to hscfn@hawaii.edu, fax to 808-956-0547, mail to Hawaii State Center for Nursing Advisory Board, 2528 McCarthy Mall, Webster Hall, 402 Honolulu, Hawaii, 96822. Each individual is allotted 5 minutes or the amount of time otherwise designated by the chairperson to provide testimony to the board. So roll call. Me, I'm here. Gloria. Hello, Gloria.
Oh, sorry, I was on mute. I'm here.
I know. Jeanette, can you hear while you're driving? Please be safe.
Yep, I'm here. I can hear. Thank you.
All right. No Linda yet. Roberta, no. Rose, not. Arthur, Big Island. You can't speak yet? There he is here in the chat room. Thank you. Dean Seriula.
Here.
Thank you. And the illustrious Laura Reichert.
I'm here.
Thank you all so much for your support and presence. Oh, since I'm such a good reader, I'll read this one too. Public testimony. Individuals who are unable to provide testimony at this time will be allowed an opportunity to testify when specific agenda items are called. For both internet and phone access when testifying, you will be asked to identify yourself and the organization, if any, that you represent. Each testifier will be limited to 5 minutes of testimony per agenda item. All written testimony submitted are public documents. Therefore, any testimony that is submitted orally or in writing, electronically, or in person for use in the public meeting process is public information and will be posted on the board's website. All right, so the agenda, we've called to order. Welcome, public comment. Laura, take her away.
All right. So we are actually, we can turn off the share screen. Everybody should have the 2018 to 2023 strategic plans. If you printed them, they look like this. As well as the annual strategic plan for 2023, which was the document that was created after our facilitated session in August of last year, August 12th, with Community Works and Lily Bloom Domingo and her team. What we want to do today, and I'm going to move to my agenda because we have the questions there. What I want to do today is we're going to review our 2018 to 2023 plans, the 2023 priorities, and then we want to go through, or we will go through a quick brainstorming activity. What can we build on? What do we care deeply about? What resources does the board need and the Center for Nursing need to pull off these activities and name the key community and county partners? And the framework for this is not to develop the strategic plan, but the strategy for strategic planning. And so this is like, how are we going to go about the strategic planning? In what format do we want to do? And what are the key pieces that we want to make sure that we have in place as we set out to do strategic planning? So this is our strategic planning for strategic planning.
Whoa.
Yeah. So if you recall, and I think this 2018 to 2023 strategic plans document should be near and dear to our hearts and very familiar. For those of you who have been on the board, I mean, at least for the past year, but for the past several years, what we've actually done is twice a year, we kind of frame our work around these strategic plans. And so how we communicate to you as board members is within this framework. Since we've done the 2018 to 2023, we've revised our vision and mission. So please note what you're looking at is old here in this document. But the strategic priorities at that time were APRN transition to practice and community-based healthcare management teams. What we've done since this time is continue the focus of our work, which we'll move on into just a second, but we've changed our strategic priorities over time. So currently, we have, wellness and educational capacity and leadership development, which we'll look at in this next document. Our drivers for strategic priorities were developed through focus groups that we held on Oahu. And we flew our members in across the state into a centralized location. We had several meetings and we had this kind of appreciative inquiry framework that we used to identify the priorities, the drivers, and then the strategic plan as well. So that's the framework we used in that 2017, 2018 timeframe. So those drivers were responsive education, evidence-based practice, home health and community-based nursing, leadership development, actionable data, and the promotion of nursing. And I've been pleased with the strategic plans and the reasons why we didn't rapidly update them in 2023, as you recall, and we had Sherry Daniels come and speak to us at that time, is that we were in such a fluctuant period of time. What was important today may not even matter in 10 seconds when something drastically different just happened and we needed to drastically respond to that. And so we moved for a bit of time to more of a tactical response to strategic planning instead of a visionary response to strategic planning as the last 4 years required. But also, these were still, I think, pretty good at helping us guide our work. So I don't think that I actually feel like we have been able to maintain the value and the nature of these strategic plans without being too short-sighted. They still provided us a runway for us to work on. So our strategic plans, we ended up, the goals and mandates, which we all know, the collect and analyze workforce research, collect and analyze data to to prepare and disseminate written reports and recommendations regarding the current and future status and trends of the nursing workforce, conduct research on best practices and quality outcomes, plan and for implementing strategies to recruit and retain nurses, and then kind of secondary to that, research, analyze, and report data related to the retention of nurses. And then the one goal that we added in beyond that was engage in communication and public awareness strategies to support strong nursing workforce and center initiatives. And then within that, you can see our objectives for the first one, if you go back up, that was really like enriching the research strategy in the center, which I think we've done. I think Carrie's like achieved this goal. Thank you very much. Certainly the promotion of accessible data. I think she has a reputation for being very responsive to data requests. So thank you for that. And then also a lot of this work throughout, you'll see that we re-engaged our community experts and our knowledge holders to help kind of give intermediate touch bases with the community to make sure that we are right on course. And so Carrie, through the course of time, if you kind of paid attention to the different studies that she's done using the same survey, there was actually quite large pieces, particularly in the workforce supply, that she's created and some elements that she's removed or improved based off this community feedback. The research and best practices, EBP, in the course of our tenure of the strategic plan, we've also really changed this. We have that nursing professional development piece with the SIM collaborative and CE provider and faculty education support, et cetera. Develop a plan for implementing strategies to recruit and retain nurses. We really have used a data-driven approach, not just through Carrie's work, but we've also started doing many more needs assessments and program evaluations that drive a better understanding about the utilization of our programs and also the ongoing needs of our community. So we have the ed capacity projections, and we have the specialty nursing needs assessment, and we've done these other works, and we also started creating, kind of goes down to the one below it. We've been creating informational briefs to improve the understanding on the status and the outcomes of our programs. And then we've used that data then to drive new work, the grants and the initiatives, the growth in our programs, the transforming of our programs into other things like APIN to nursing professional development and NRP to nursing transition to practice program. All of this has kind of happened because of that data-driven approach. And then finally, and those are the conduct research and develop a plan kind of go together. And then we've also used that work to start new initiatives like the preceptor tax credit and the HRS review. So being responsive from a policy perspective, using those needs assessments as the driver. And then engaging in communication and public awareness. I think we still have the policy part of this, communicating data to policymakers and decision makers. I think we're very strong. I think in some of the other areas, maybe like the public perception of what's going on in nursing, I can do a better job. So, but I want to share, I mean, the emphasis of this framework and what we did in the past was using our mandates, but then talking about what the needs were during those focus groups. And then the outcome of that was saying, like, what can we do? And the goal of the strategic plan was to give a little bit of a pause for our team. That did not happen. But the goal from a strategy perspective, when I looked at the past strategies before, from the inception of the center to 2015, there was a new the strategic plan almost every 15 months. And so the goal of this was to actually stretch out the time where we're working on things we can achieve. And I think the outcomes have been tremendous. So I do think we've achieved the aims. We've transformed programs. We've gotten rid of some programs. We've developed our own expertise a bit more. And then you can see, and I won't go through it because I kind of described, but we did have a roadmap across those 5 years. We did have a roadmap to kind of take us through. So do what we're doing and then start to analyze, like, do we still need to do this? Do we need to adjust? What can we put down? What can we pick up? Unfortunately, in that when we get into the orange and red, that's really what we were feeling at that time as well. It just really was an intense 4 years where we weren't able to actually put down that many programs and kind of move into a phase of innovation, because the needs of our existing programs, what we needed to do was expand them. And then secondarily to that, there were so many new things that kind of popped up in this environment. So I think some of the goals that we had, where we were developing maybe new programs or redesigning to really match the future, that couldn't happen because of that 4-year period. But I still think that we were on a pretty close, we were pretty close within this. I think it has led us well. I think it was a good guide. It was a good framework. I think the communication from our focus groups, the way we brought people together, improved public relations or our partner relations. I think we were able to do better program and program outreach because of that inclusive nature of the conversations. We were able to actually, and I think Gloria, public health, I think because we had we had maybe 3 or 4 public health nurses, but many more than just the director. What it really helped was triangulate that information and give us more perspectives from one specialty or one, for example, for one specialty or one professional area. And that helped us continue to reach out to those partners. And then you can see here we actually have definitions and guidance behind our strategic priorities. So moving from that and then moving over to the annual, the strategy for 2023, and this was more of a notes version. We didn't end up articulating it into a clear and clean, concise document. This was more of kind of like a framework. But if you go to the end, the new and enhanced opportunities for the Center for Nursing, actually, that's quite the middle. But what we started to do is identify these like big themes and trends, priorities that you all communicated from your expertise, your region, your specialty, your network, et cetera. And as a result, we landed on some priorities, which kind of can be summarized into wellness and all of the sub-threads within wellness. Then we have the educational capacity, which is NCLEX, and it's faculty development, and it's clinical placement slots, and kind of everything that works within that. And then we have this leadership piece, which within that, it's that public health nursing development, specialty development. It's leadership training for nurses. It's helping nurse leaders understand and how to be advocates, and implement wellness initiatives within their whether it's listening to their nurses and validating what their team says, or bringing down the initiatives from leadership down and making sure that there's not that bottleneck of communication. We have made some, but not much progress on these priorities because we continue to be in this kind of fast and furious pace. We had a lot of projects that were coming to completion at the end of last year. We had that very large SIM conference, we had the very large nurse license compact study, and then the legislative session that coupled with that. So we are making there's been a lot of conversation, but I would say we're in many ways, we're still in the planning phase for these priorities. I wouldn't say we can put them down. I don't think that the needs have been closed. We haven't closed those gaps. So where we are now, having gone through, does anybody have any comments? Do you have any memories, recollections, additional input, disagreements? Okay,
I'm
so
always stunned how much you guys get done.
I know we told I was telling Gloria before the meeting started that we met with a DOH colleague of hers, Ruben Frescas, and I was like, we're a really mighty team because we're 7, but by FTE, we're actually 5. Like, we're really actually small. but it's the collaborative nature of our work, right? I also often say that we're like a nursing think tank, right? Like we bring in all these bright minds and this like energy and the care and the drive from the community. And we kind of we can organize it and help it happen. But it is that community input that makes it so powerful. So here we are. Okay, so we just did the review of the 2018 to 2023 plans, which I continue to be very grateful for. I'm glad that we've had something that the last couple years of the plans have been able to stretch. But the risk that I am concerned about, and I have some literature sitting in my office somewhere, when you do strategic plans, there is tactical strategic planning that's 1 to 2 years out. There's visionary strategic planning that can go 20 years out. And then there's kind of in between. I think because we have had so many changes in the nursing workforce and our population, just because of COVID and a pandemic and, all that did just to society, not just healthcare, we would probably be remiss to try to have strategic plans that go 20 years out. We may not have the foresight today to be able to imagine what the future potential could be. But I also feel like we would be remiss if we keep on doing a 1 to 2 year strategic plan, because we won't be getting ahead of the challenges and working on long game strategies that will have lasting impact. And I'm concerned about that because we are in many ways very fragile as a workforce and in society. And we as nurses have to be a backbone of health and resilience for the community. And that is like no small lift. So the Center for Nursing has to be responsive to that responsibility of nurses. So I'd like to do not just because we've kind of run out of time on our strategic plans, but we're also at a really good time to kind of capture that energy and momentum. The questions we have today that we want to work through as a dialogue are, how can we engage? What is the best way for us to engage in strategic planning? We will take this information to find the right consultant for strategic planning. We're not going to value engineer this. We'll pay for the right person. But we want to have the right framework. We want to be able to ask for things so we get the right person to help us develop these plans, like we had back in 2018. So the first question, and I wonder, Bree, maybe if we can take the screen off and we can put these questions into the chat so we can see our faces or our names. If your camera is off, and that's fine too. So the first question is, what can we build on? And so from this value proposition, so think about this, like both kind of what do we need to do for strategic planning, and then a step backward, or what do we need to do as our strategic plans? Like, what do we want to achieve? And then as a step backwards, what do we want to make sure we get out of our strategic planning process? So what can we build on? What was good about our strategic plans? What's good about our community? Any of those things, and just kind of any answer you say is the right answer. Let's go.
Well, all those who's were really good. The sim hui, the executive leader hui, all those groups that came together. It's kind of a bunch of people that might not have made it all together at the table had you not facilitated. And, you make whatever goals you got out of those specific meetings. I venture that there is other goals outside of that meetings that you connected people with. So that strategy and your ability to do that was really something to build on.
Thank you, Anne. Arthur, I think you're having sound problem, and Jeanette, I know you're in the car. So if you remember these questions, and Arthur, if you can put them in the chat or respond by email later. I also want to be respectful of the technological and remote challenges that we're having today. And bandwidth problems. So, yeah, so if people need to make comments by chat, we'll just read them out for the group. And Bree and Carrie, I would also hope to hear from you all as well, if you have thoughts to offer. So what can we build on? So we have the WHOIs, and then we also, and you're right, and we do have a lot of goals that each of our WHOIs have articulated, and it's very easy for us to put them together as kind of a leading framework of like, what are things that people still want to work on? Jeanette?
Yeah. Thanks. I think I'm parked real quick here. One thing that we've been seeing, or that, is of interest, that I think we really should be keeping an eye on, is the nurse turnover rate. It seems like nationwide, looking at, trying to address that, or even how to reduce it, because I'm wondering if like that may become a trend in the future. We may be seeing more, whether it's new or seasoned nurses, but just kind of looking to make sure that doesn't become more of a pressing issue.
Okay. No, that's good information.
Can I ask you a clarifying question?
Sure, yeah, absolutely.
Are we talking about like broad retention, like seeing to that we can hold on to the nurses who are already in the workforce? Are you talking about like job turnover, like in a position we're seeing churn, or people not staying in a single position a long time? So you're talking about big picture nursing workforce retention, or are you talking about churn in a specific setting or position type?
That's a good clarification. Actually, well, that's what I'm curious about, because I'm not real clear on what our state trends are. But look, it kind of seems like it's a little bit of both, but from what I'm hearing out of state, there's the turnover that they're seeing, especially in the acute care setting. It seems like nurses are just leaving completely, like, and not even returning in another sector. So I'm just, you know what I mean? I'm just curious if, because we don't want to lose them altogether. Because that's the nursing workforce that we, so yeah, and I'm not real clear on what those rates are, or how it's affecting us statewide.
You.
But I mean, I just kind of lean, because I know that the cost is really high, for the cost of the turnover, to replace nursing staff. And, maybe it just is looking at, like a deeper dive as to what could be contributing, whether it's in the acute setting versus, because it could be anything from work environment, work-life balance, especially I know with the pandemic, that was a really special situation, and kind of to be expected during that. But it seems like it's still kind of like, I feel like maybe we should have had some improvement, but maybe it's not. We're still kind of maybe in that trend.
I heard two things kind of from your last comment when you were talking about the cost of turnover. And then I kind of heard one is, what is the cost of turnover? But underlying, I also heard, and I think it goes back to the beginning of your comments there, what are the contributors of the turnover, which is two different things, right? Like what is causing the turnover?
Right.
And then also what is the impact on the healthcare system?
The effects, right? Yeah, right.
Okay, good. Arthur, I'm going to read his chat. Arthur says, standardizing basic nursing competency for novice nurses. There's a new national organization who's focusing on that, and they're developing their research. They're called iconed.org. And nursing well-being. Okay, that's great. Thank you.
No, building on the responsive education. So training more faculty to be clinical, to be well-equipped to teach in the clinical areas, as well as expanding clinical placement. Also seeking and obtaining, securing funding for faculty salary or compensation.
Okay. Faculty development, salary. And you said clinical placement. Okay, that's great.
I think that's a good point, Clem. Because we also look at, like, you know, with the new essentials that AACN is unfolding, is looking at that closer at the, you know, the
Mhm.
educational level, what
Right.
we're doing to educate these nurses, but also, you know, importantly, there's so many factors, right? Like, you know, the safety ratio, the, you know, all these issues that kind of tie in, but also I think we just really don't teach nurses, because we're such a caring profession, you know, we don't take care of ourselves. And
Mhm.
so really being mindful about their well-being, and starting with us too, you know, starting with that education too, how to care for themselves, and to, so they can continue to care for others.
Yeah.
Mhm.
If
Yeah.
you've met a nursing faculty, it seems like the trend is like you work 120 hours and then you drink a cup of coffee and work 8 more in a week. It's like,
Right.
which that's a hard model to be like, yeah, I want to choose that for myself too, right? Like that's, you know, it's a hard job.
And
Okay,
get paid a little less.
yeah, and then get paid a little less, or
Yeah.
depending on the county, half. Yeah. So I think that kind of, I mean, all jokes aside, and I don't mean to be dismissive by making those comments, but maybe it's not just salary, but I'm hearing it's also kind of like that workload to compensation ratio, maybe, or
Mhm.
whatever, workload to compensation, something. Let's see. I want to move on to the next question. And this
Oh,
can kind of be
Bree has her
oh,
hand up, Laura.
Oh, Bree does. Sorry, I missed that, Bree. Thank you, Clem. You're muted. There you go.
Can you hear me? All
Yeah.
right. I just wanted to know, in the 2018-2023 mandates, plans, goals, and objectives, we had added the engage in community and public awareness strategies to support strong nursing workforce and center initiatives. And underneath those, a couple of them are things that we have really expanded our capacity with, that speak to almost all of our issues. And one of those is, you know, advocating for sound nursing and health policy using data-driven strategies. And a lot of what we have focused on these past couple of years is helping to provide those data-driven strategies, and helping to provide the data in ways that really kind of narrow down the focus by all of the massive amounts of infographics that we put out, and all of Carrie's supplemental reports that have been fantastic, the briefs and all of the other stuff that we do with our clinical placements. And in addition to that, one of those was engage with national initiatives to ensure that our healthcare is grounded and in national best practices. And we have really made an effort to expand our integration with the national, because it's been, you know, for a long time kind of very far off. We were very state focused and not really looking at the national in a lot of other areas. And I would say that all of those things really speak to almost every issue that we're encountering and we're discussing,
Yeah.
and making sure that we're grounding those in all of these extra things that we do. And I would recommend that we continue to adopt that as an additional thing that kind of goes above and beyond our normal legislative mandate. I liked the addition of that, and I would just say we should keep it in going forward.
Well, that's a great segue, Bree, because I was going to go to the next question, which is, what do we care deeply about? And I think you just answered that question really well. I think I in particular also take a lot of pride in our ability to articulate the policy needs from a data-driven or an evidence-based initiative. And then I think we've been doing better. Oops, sorry about that. I think we've been making headway with those national initiatives. And as we get more connected nationally, then we are doing a better job connecting with the right groups. And a great example is actually during one of our board meetings, I think it was February 2021, Rose was away because she was at the HSCN board meeting and it conflicted. And she, during our meeting, texted me the nursing staffing think tank. So her connection to that national organization is what put us on that pathway. So I have data-driven, data-driven policy and the national initiatives. Do we have other things? What else do we feel? I have to read it. What else do we care deeply about? Arthur, I'm just going to recognize that because you wrote it already.
Yeah, I got it. I
people
figured out my
being-
Zoom thing.
It's so nice to hear your voice and also to see your face. I'm glad that you're,
You know what
you're
happened?
back and you're with us.
No, you started the recording before I unmuted myself. That's what happened. I didn't realize that. Well, hi, everyone.
Hi, Arthur. Do you have any, so in terms of what do we care deeply about? I think, Arthur, your comments that you had chatted might also be something that you care deeply about. I'm just gonna go on a gander with that one.
Yeah, well, it's number 2, right? What do we do care? I think nursing well-being is everybody's looking at it right now. But just implementing what techniques that we could use, or we've been doing some webinars, we've been in some training. We've got this RISE program that we're looking into, and there's multiple things that we could possibly do. And it's the impact on the nurses now, especially the younger ones. I mean, they're having a hard time dealing or coping with death and dying, working long hours, and not having time off. I mean, it's a different type of workforce, and you can't just tell them to suck it up like before. So we've got to find the right approach and give them the right resources to help them be successful and not burn out earlier than 30 years, So that is my number 1 thing I'm working on. And I think everyone feels the same in a hospital setting for sure.
Thank you, Arthur.
It's interesting that you should say that, Arthur, because when we were evaluating our students' progression, retention, we noticed that since coming back from the pandemic, the students' resilience and grit is just not there. I mean, they have over 4.0, but social skills and their ability to adapt is not there. I mean, we're having to, in fact, we're trying to decide what we should do with the direct entry in nursing program, where we admit them directly from high school because they're just not mature enough, right? I think it's not fair to send them out there immature and then in less than 3 months they'll leave nursing because they don't have the maturity, resilience, grit that now our very complex healthcare system requires of our nurses.
Having them just sit and talk story with the patient, that is they can't do that. It's so hard for the new novice nurses to do that. And that's where you build the rapport and the rapport and trust from the patient. I mean, that's the biggest. This talking story is one of your assessment skills, and they can't. That's a piece that's missing.
Can I ask, when you say they can't do that, is that because their workload?
No, they're just
How, or
uncomfortable.
it's
I think they're just uncomfortable, and that's
It's
I don't
the
know.
interpersonal
Just my,
skill, like,
my personal observation, it's just,
Okay.
I think it has a lot to do with technology, right?
yes.
They're
yeah,
used to
they're-
texting as opposed to talking directly.
Right, exactly. You said it, exactly. I mean, they'd rather jump on the phone or jump on a computer than sit and talk story with the patient. I mean, and they don't do that anymore.
in my very random analogy-based mind, I'm just imagining like a new clinical where you just have to have eye contact and
Yeah, yeah.
like you just practice talking, because I mean, you practice
Throw
listening
me
to
in a room
heart.
with the new grads. Put me in a room with the new grads. That would be
Carrie's
like
gonna lead
my
that
greatest
course.
day
It's gonna be
ever.
curriculum development, and we will be world breaking. Is that the phrase?
I don't want
Yeah,
to
your
break the world,
specialty,
but
Carrie.
it's right. Like, throw me in a room with them. It'll be great. We'll all have fun. They'll cry a little and it'll be fine.
Miss Doctor of Interprofessional Communicate or Interpersonal Communications.
Correct.
Hey, that is some webinar we might need.
When we put on the WUFAR training, we brought California Health Impact out last month, and we had the clinical instructors sitting in this room, and the California folks were talking about, kind of trying to create innovation in nursing education and whatnot. And I'm sitting at the back of the room going, I gotta get with some smart nurses and build a course that is like basic interpersonal, but applicable to the clinical setting. And so I'm actually trying to figure out how to build that course, because I feel like that is how I can contribute to
Done.
nursing education with my
Time
expertise.
allocation, done.
Yeah.
What
be so
money
much
do you
fun.
need to put it on? We'll figure it
Yeah,
out.
I don't even know.
Can I
Figure it
add to
out.
that? So one example is, like the family members, I mean, that's where you get most of your information from. I mean, they don't even talk to the family members, I mean, that's where you get all the history and what's going on and trying to do your
Like,
critical thinking and
how many
that piece
pills
is
are on the
not
floor?
Yes, that's actually one of the units I put into this course that I'm building in my mind, is how to elicit information from the family members. It's not just, it's like soothing and comforting, but also eliciting information from
Yeah.
people who are stressed.
Yes.
Yes. Yes. I'm working on it.
All right, we're gonna trademark that.
And though, to your point, Laura, I mean, I was in clinical today and it was a wild day. And 2 of the nurses told me, I don't even get to talk to my patients anymore. I mean, they wanted to do it. But their hair was flying backwards.
We had a comment, Bree and I met with a nurse leader, and she was commenting on the workload. So she made the example that when you have 5 patients on a PC, she was talking about a PCU unit. She's like, you got 5 patients, 3 of them discharge. You get 1 new admit and or 2 new admits and you get 1 downgrade from ICU. The 2 admits, you have to put all of the drains, all the ports, all of the ins and outs and, IVs, antibiotics, everything. That takes a lot of time. And then you have to do the patient orientation, you have to do the family orientation, you got to do the care plans, you got to put the orders in, et cetera, et cetera, et cetera. She was making, she made this very clear example. And then with the ICU, same thing. And then you have these 2 other patients who aren't like small fish to fry. And one new patient to your panel, your 5-patient panel, may take you an hour and a half. But if you're having to split your time equally between 5, you're just not finishing your work. And that really, her comment really clarified to me, when we talk about acuity, but it's really workload. And what clicked for me as a geriatric nurse practitioner, like, sure, we have 15-minute visits. You have a sinus infection, sure, I'll get, clear as mud. But a new patient orientation can be an hour to an hour and a half. And that is baked into our coding, so it's the workload that is different. And I was like, oh, and that's what I've been hearing around, but I don't think it kind of clicked for me for acute care. We talk about it a lot, right? Arthur on the CNO nurse leader but then I think hearing that there's not a scheduling model that addresses acuity and workload and all of this other to kind of really adapt how many staff you need to actually do the work properly, right? To include talking to your patient and not just whipping through a whole bunch of tasks. So that's something like, I don't know how to. I don't think that's necessarily within our grasp. I think that's something that we have to do national or international partnering with, but it kind of gelled. And I think going back to the critical thinking and the essentials, you know, you can't just be teaching tasks. You have to be teaching why the tasks are done. Because you have to be picking up the pieces that might be getting dropped along the way and whatever setting you're in. But so I think that workload piece is probably going to be a bigger topic moving forward because the patients are so much sicker in every setting. Like Gloria, I'm sure your patients are just like fine. They're just like looking for a friend, right?
Yeah, and mostly that way, but the number of cases here,
Yeah.
because of schools and the community work, sometimes they can get up to 100 cases, and trying to make contact within a month, every month, becomes difficult.
And I'm sure by the point that they need your support, right, as a public health nurse, it's not a 30-minute phone call.
No, it's not. Sometimes it takes about 2 hours just to get through that one particular concern or need.
Yeah. So the conversation I've heard nationally is the value of nurse, but I'm starting to think that's the wrong word. Like, of course we love nurses, you know, but like value isn't descriptive enough. So I think, so what I'm realizing is that the words that we've been using haven't facilitated addressing the problems in a way that will lead to outcomes. And so it's something I care deeply about, is trying to understand and articulate better what the challenges are so we can be direct in the solutions that we bring. Because the value, like, I'm like, what is that? Like reimbursement doesn't bring in more people, or it doesn't change workload, or it doesn't modify, you know, XYZ. So.
I mean, not to be, you know, hysterical, but you know, if you don't have enough nurses and they can't do their work, people have worse outcomes all the way to death. I mean, they rolled some guy up in ER today on BiPAP and he's coming down the hall snorting. It's like, what the hell is he even doing on this floor? And about 60, 90 minutes later, the rapid response was taking him to ICU. And you know, if you don't have enough people on deck, and you know how many people that took to manage that hour, and who knows those other sick people there, the bottom line, with not enough adequate numbers and prepared help, people can die or have bad outcomes. So, I mean, it's value sounds so nice. Oh, we trust nurses. Well, without them and enough of them, you can die.
Yeah. All right, so if we can move to question 3, to pull off, having kind of sitting with the responses that we've just had, what can we build on? What do we care deeply about? And if any of those questions pop up and you want to add them in, keep on. But what resources do the board need to help the Center for Nursing facilitate a new strategic plan? Like what should we be doing? I just want to say we will be paying for a consultant. So please know that is a resource that will be made available. But what else is needed?
Do you have 5 FTEs because you can't find the right people?
A little bit, yeah. I've created 3 job descriptions, not Juris Doctorates. I've created 3 job descriptions. We ran 2 of them twice. And there's just, you know, with a workforce shortage, it's just hard to find. We had really cool applicants, but they weren't for the job that we were looking for. And so you know, you can't hire someone that is, you're like, well, you're a neat person. They were all great applicants, but just not for the job. So I think one is maybe the job descriptions need to be improved. And two, we just have to keep on trying. We do have money though. We have money to pay people to work. And that was a prior, so we weren't looking to expand before the license fee increased because we did not have the money to expand the team. But we have money now. Thank you all for your work.
Because kind of
Laura,
like the workflow, the work load discussion, I mean, that kind of comes on you guys to how far you can dream and expand and, you know, do more stuff. I mean, I like the
Yeah.
data in every fashion that it comes, but Carrie can stay awake only so many hours a day. So, you know, it seems like there may be a ceiling just on that level.
Yeah. And we're having some discussions, actually, Clem and I were talking about it today. One is looking to expand like an office assistant. We don't have an office assistant. Everybody's kind of programmatically tied that can also facilitate our fiscal office that is just like, takes a lot of work to spend money, you know, and being within UH, it's a large bureaucratic process. And so that team needs, you know, that aspect needs help. The wellness initiative and also kind of pulling together all of these things that we hear, and when they do have policy implications, having someone to help articulate that work, it does take a lot of work to do that. And then maybe even possibly we write grants and we reach out, but we have had frequent instances where a great notice of funding opportunity comes out, and then even like a community partner will say like, I can do this grant, but I don't have time to write it. So maybe a resource not just for ourselves, but for the community is having a grant writer on contract. So those were some of the activities. I think those are maybe the short list. We've also there's been suggestions for a marketing manager, someone to help articulate and push out that information. It's also kind of uncomfortable to talk about your own work, so it's helpful when somebody is like, no, that's the great message. Clem has someone who's really great at manuscript writing, and we've bought out some of her time to assist us, and she's helped with manuscript writing. But yeah, so that is top of mind. Expand.
Arthur has expand outreach, maximize participation from nurse leaders from multiple organizations. I was just thinking, I think we do need to hear perspectives from our nurse leaders, from the practice setting, and the various practice setting, from the academic setting, but also from nurses themselves. What are their needs? What struggles do they have?
Yeah. That's one of the harder things for us, Clem. We get pretty fun participation in our webinars. I would say we probably get more staff level nurses than any of our other programs. But it's really hard. And so maybe we could do a webinar where it's a focus group, but it's really hard to get in touch with staff nurses. We've tried for years to get a bedside or staff nurse on our board. And like, you know, it's really hard to get them. Yeah, and we're still trying to Bree's point. But I agree, Clem, I think that's a great. Okay, so what the board needs, recognize it could have more staff, expand outreach, maximize participation from nurses, leaders, and multiple organizations, hear perspectives from leadership, academic, and also staff nurses. Moving on to the last question, I think, yeah, name key community and county partners. I mentioned this at the last advisory board meeting. In 2017, when we did the strategic planning, we brought people to Oahu. And I would instead, for this iteration, like to take whoever the facilitator is for our strategic planning, and then like a few board members and a few staff, and go to the islands. And so we go around. So we'll need your help, Neighbor Island board members and friends. for that, for the location and the venue and stuff. But so put that in your mind, we're planning for that, but what other key community and county partners?
I think that legislators, right, are important. You know, you and I go to the legislature a lot, but this past legislative session, I had to meet with many of them more than usual because of what we were going through. But the key takeaway I got was that they don't know what's happening, right? I mean, if we want them to vote a certain way, if we want them to fund us, we need to let them know what's happening, right? We need to have a relationship, engage them.
Yeah.
Another thing I was thinking about, because it gets difficult sometimes with training new nurses because of the task versus the critical thinking, which has to be integrated in there. But another thing that probably needs to be integrated in, we do have some of these community and county partners, are like Office of Health Equity and things like that. To be so that we're using the interpreters when we need to use the interpreters. We're explaining, you know, using 6th to 8th grade language or words. And so looking at those things where I know when I started nursing and started doing the acute care side, I was so afraid to speak Pidgin. For like the first year and a half, 2 years, I didn't speak Pidgin. And then I realized, hello, these people are majority of them are from Hawaii. They understand Pidgin and it makes them feel a little bit more comfortable. And so that is what kind of helped me to break through that barrier and begin to not just fire off questions, but engage in talk stories for a little while, even if it's for 5 or 10 minutes. But talk story to get through doing some of the assessments rather than just firing off questions.
Yeah. Jeanette?
Yeah, hi. Can you hear me?
Yeah, you sound good.
Okay, good. It says safe driving mode, so I'm like, I don't know if it's unmuted or not. But I'm not sure if this ties into question 3 or 4, but kind of like stemming off of what Clem and everyone was saying, but maybe engaging even some of the community partners or to determine if what their needs are, like, are they initiating like wellness programs for their staff, or is there, you know what I mean? Is there something that they're aware of or that they've identified that maybe they need support too in some way that we could support them, or that, you know, even through the legislators that it could be, you know, brought to light? So maybe like collaborating with them on that. I'm not sure.
Yeah, that's great. Like, what are they doing or what do they need, but being really inclusive and who are asking those questions too. That kind of
Yeah.
cool. Yeah, thank you. Thank you, Jeanette.
And I know that we cannot meet with every single person, even if we're traveling through the counties and stuff like that. But is there data that can help us to identify who has the most need and maybe prioritize as we look to meet with key community and county partners?
You know, to build on that, Gloria, not who has the most need is also, there's pockets that have need and resources. For example, the Wailea Community Association is a neighborhood of basically elderly retired people who are very interested in being able to get good health care because they live here and we're in the middle of nowhere. So they're, at risk for all the things they're at risk for. And they have money and influence. And so they're very open to hearing the stories of what are mechanisms that could improve the health care system that they have to use. So, I think many know the legislators, and they've, fiscally supported us really strongly, but not just engaging them for their money, but, AARP has a big political arm where they try to get all those voices in the right direction, because trying to change how crazy things are right now is going to take a big muscling push. But those kind of people are good to have on the team too, and see how they, look at the world, what they see as could be influential.
Yeah. Yeah, I think we tried doing some of that, and for a while, the transitions that happened during COVID, we lost connect, but we had made a good connection with it's called C-Arch. I forget what the C stands for, Coalition of Adult Residential Care Homes. Right, but it was because we were also trying to get some of those special interest groups. So I had found a lot of value in that as well in the past. And I think there's a lot more groups there's more groups that have better articulated their interests in the past couple years as well. So it's always good to do another landscape assessment of kind of who's out there. I think the other thing, because we talk about cost of living as being a factor of recruitment and retention, probably reaching out to those folks as well, right? Like there's so much going on, but how do we make sure that we're not siloed with those conversations? I think we only had 3 questions. Oh, no, yeah, no, we had 4. What board? Name key community and county partners on the second page, sorry. So we've gotten through all the questions. Are there other things that you want to thank you, Arthur. Okay, so obtain feedback from the end user, patients, members in the Rotary and Chamber. I also wonder, Arthur, or maybe Jeanette and Clem, maybe this is a question, like, are also the end users in some perspective, like students navigating the educational system? Like maybe it's the pre-nursing students who are trying to get into nursing, you know?
Yeah. So we only admitted 22 out of 748 direct entry in nursing applicants. I'm sure they have a lot to say.
I don't know, Clem, if you saw Carrie's reaction. That's so, I think it's so painful to me to hear that, I'll say, because I have people who are like, yeah, I tried getting into nursing school and I was told I'm like not smart enough, and they're brilliant, wonderful people who would be incredible patient advocates and colleagues. And I'm like, what a shame that nursing is so competitive that we have to turn away so many. And I'm like, well, you're doing great in your job and you're making such a wonderful contribution. So thank goodness you got to where you are right now, right? Like that doesn't stop the person, but it does, I think, inhibit nursing when it's so competitive that like, are the metrics not enabling us to capture the people with the grit or whatever,
Right,
like
right.
what is,
Mhm.
I'm
the
glad there wasn't
criteria
a
for
requirement
admission.
back in the 80s.
Say that again?
I'm glad that that GPA wasn't a requirement back in the 80s.
But tenacity was, Arthur.
Yes, hard work.
Yeah. All right, so we've kind of gotten to the end of this thought experiment, which I found to be very meaningful, and it will certainly help focus questions to find the right consultant and also schedule out kind of like how we're working on the next steps for strategic planning. Thank you. One question Bree put in the chat was if we have a preferred location for the August meeting. Does not have to be biomedical sciences, C-Court. So if you have suggestions, we will take them. I mean, it's also it'll be in that time frame for strategic planning. So if we want to go to another island, we can do it. So let us, put in requests or suggestions.
Yeah, maybe we should send a poll out to see if we can't get everyone to kind of respond with some ideas about where to have it. I mean, we've had it at golf courses. Last year we had it at Chaminade, which was great. But there's a lot of other opportunities and locations to have it at. Although, a day at the golf course is not a bad thing, but
Yeah, so we can be creative and we can find a good location, and we'll just have to make sure that if it is a location, it needs to hold a little bit more than us in case people of the public want to attend.
Or I'm wondering if we don't have to go to the Low E, but that Native Hawaiian place down by Dole Street. Are you familiar with that?
Oh, on UH campus?
Yeah, it's really
Oh,
pretty.
yeah.
Yeah.
Papakanay.
Mhm. Okay, yeah, that's a great suggestion. Thank you. Thank you, Clem. All right. Well, moving on. Do you want me to take it, Anne? Or you want to make this great announcement?
You go, you're the bomb.
So there are many of us who will be attending the National Forum of Nursing Workforce Centers. Carrie is presenting, I'm presenting, oh yeah, Catherine's presenting, Leanne's presenting, everyone's presenting, like the whole team is presenting. Is Catherine not presenting? No, they got it accepted.
She's on
They didn't submit anything.
sabbatical.
They didn't
Yeah,
submit
she's-
anything.
Oh,
Yep, no.
man.
No.
I
I
thought
don't-
everyone
yeah.
was presenting.
Yeah,
Sorry,
Leanne
Carrie,
didn't
Bree,
get
and I are
Catherine.
presenting.
Yes.
Catherine, Leanne, and Anne will be attending. And I'm just so excited. I don't have my facts straight because the fact I do have straight is that Carrie is getting the first award for the National Forum member recognition, which means that she is a fantastic national contributor to the National
You
Workforce Centers. Ever
fantastic.
award.
Yay!
Gonna teach myself how to string lay because I don't think I will be able to bring one from Oahu that will stay fresh 4 days in.
You
Thank the
should
boss for
check
the
with
nomination.
Holly how she did that.
I will find out.
Yeah, even
Holly or
Catherine,
Nancy knows how to
she
get laid.
remember when you folks got inducted to FAN?
Yeah.
She was in charge of the lay.
So that is really exciting news.
That's awesome.
And I'm really excited. If you would like to know all the things that Carrie has done, she is a mentor. She helps with national training. She has helped with the member survey. She leads like 2 committees. She makes sure that committees talk to each other, all the things that Carrie does. And she does this for the forum as well as for us. So I'm very excited by
Thanks for the nomination,
Congratulations.
boss.
this. You're very welcome.
Thank you.
Does it come with a $10,000 reward?
Oh, the forum has no money.
Probably comes with a hug from
Might
somebody
come
I
with a
probably
piece
don't want
of
to hug
paper.
from.
Yeah, a bonus.
It's the appreciation that matters.
We will toast you.
Yes.
down for that.
Yeah. So that is the huge
Awesome.
news. I should say, I'll say that's about myself, but I should also say with that is that I also got into the Omidyar Fellows Cohort 9, which is a pretty big thing locally.
Hey.
Oh my God. You know what? That's
Got
right.
it.
And next year's strategic planning maybe can be like your project or something. I mean, what's going to happen because of that to this center is just, you know, the sky's the limit, Laura. Who
They,
knows?
what I hear about the Omidyar Fellowship is that a lot of people, like what they just how they describe it about themselves is like when they're at this feeling of like, oh, maybe I'm getting burned out, maybe I should just kind of do less, like I don't know, they like
Right.
it flips that switch and it's like no, full gear, like full steam ahead, and it really
That's
gives
awesome.
them not just the energy but the network and to do it. And I think that's a really exciting prospect because right now, like we don't have small problems in nursing. They're all huge problems. And it's like, you know, when your house is so dirty, you're not quite sure where to start cleaning. Like it's one of those things that it's too big. So I'm really hoping that that actually is the energy that the fellowship brings to us as the center. And I am sharing the reading lists. So get ready for it, team.
That's awesome.
Yeah.
How many fellows get in?
15.
15?
Yeah.
It's probably like a nursing class set of applicants too.
There are some great ones. There's a lot of people in healthcare. I was just looking. It's a pretty exciting, I mean, they're all really incredible groups, but this one has quite a few people who are in a healthcare space, which I think will be really interesting for the coming year.
Wow, that's so great.
Yeah.
When does it actually start?
Oh gosh, I have that piece of paper somewhere.
What, like summer or
It starts,
fall, like school or what?
yeah, it starts pretty soon. And I don't know where I put that piece of paper, but it's literally sitting on my desk. It
Hmm,
starts pretty soon.
cool.
Yeah.
All right. Is that everything?
I think that is, yeah.
Well, what a great group of people. I'm so thankful to know you all, and I'm so thankful for this center. And all the people who don't know about it don't realize how much you've helped. So thank you and have a great night and hasta la vista, babies.
We ho.
Mhm.
Thank you all so much for your great contributions today.
Thank you.
Yeah.
Good night.
Good night,
Bye,
everyone.
good night.
Night,
Bye.
everyone.
Bye.
Good night.
See you
Okay,
guys.
boss.
Take care.
I
Bye.
took some notes during the brainstorming. I dropped them in the advisory board meeting folder.
Oh,
You're
fantastic,
awesome.
fantastic. And I also did run
Otter.
an order for the meeting as well. So we've got not the summary, but the full transcript should also be helpful. And I'll export the chat. So we have that.
Okay. Yeah, and I also have notes, but I can scan them. I can annotate, I can rewrite them.
You'll have to translate them